Thank you very much for joining us today in AOR's ninth installment in our webinar series 2012.
So today we're going to talk about joint pain and inflammation. And the title of it is Pain, Pain, Go Away, because most people who have joint pain and inflammation are no stranger to pain. So about me, undergraduate degrees in kinesiology and health sciences, also a degree in business and economics. After I finished school, I also did a certificate in training in athletic injuries and how to prevent them and how to treat them. Also a naturopathic doctor and currently the medical director for AOR. So today we're going to talk about arthritis, and we're going to look more specifically just at the top one here, OA, but go a little bit over some of the most common types of arthritis. Some of the most common types that we see is OA, also known as osteoarthritis, RA, also known as rheumatoid arthritis, SLE, known as systemic lupus erythematosus, which can cause a form of arthritis. Gout can occur with joint pain and inflammation, and JIA, or juvenile idiopathic arthritis. So looking at rheumatoid arthritis is an autoimmune disorder. It can occur at any age. Most commonly, we find that it presents itself in about middle age, and also women get RA more than men. Mostly we see the wrists, fingers, knees, feet, and ankles, the most commonly affected joints. And joint pain, one of the signs of it is joint pain is often felt on the same joint, on both sides of the body. Looking a little bit at SLE. SLE, again, another autoimmune disorder. Can occur at any age, but most commonly occurs in people between the ages of 10 and 50. And when we're looking at ethnicity, African American Asians are actually more affected by SLE than any other ethnicities. Almost everyone with SLE has joint pain and swelling of some type. Some will develop arthritis because of it. Most commonly, we see fingers, hands, wrists, and knees. But SLE can also affect other things such as skin, kidneys, brain, and other organs. And SLE can actually be brought on by certain types of drugs. Looking at gout. Gout is a buildup of uric acid that builds up in blood and can cause joint inflammation and that pain. Usually involve one or a few joints. Usually the big toe, we can see up in the top right corner a picture of a toe thigh that's on the joint, big toe. Knee, ankle joints can also be affected as well. And gout is more common in men, but women in menopause experience it more than women before menopause. JIA, again, if you're noticing the theme of these ones here, another autoimmune disorder. Most common form of persistent arthritis we find in children. Most commonly occurs in children from the ages of 7 to 12. First, we see it manifest usually as limping in a child, but then after we see limping, the child can also become quite ill and present flu-like symptoms. We usually see persistent swelling of an affected joint or joints, can affect multiple joints, commonly includes the knee, which we can see in the picture at the top corner, knee that is swollen. The ankle and wrist and small joints of the hands and feet can also be affected as well. And then the most common type that we see, the most common joint disorder we see is osteoarthritis, also known as OA. It's due to aging and wear and tear on a joint. It's usually related, the older in life we get, the more common we see it. Symptoms of OA usually appear in middle age. Almost everybody has some symptom of osteoarthritis, whether joint pain, inflammation, any swelling, anything like that by the age of 70. And pain and stiffness in the joint are the most common symptoms that we see. So here we have a radiograph of a healthy knee and an arthritic knee, the figure 2. And you can notice some differences between the two. We can notice with the figure 2, we have joint space narrowing, which is different from the normal knee. And this is where the joint becomes smaller in terms of the spaces between the articular surfaces. We'll keep that in mind when we talk about glucosamine later. You can also see bone spurs, also known as osteophytes. And these are bony projections that form a long joint and are often seen in conditions such as arthritis. The bone spurs are largely responsible for limitations that we see in joint motion and can cause pain. These bone spurs is basically the body's way of trying to increase the surface area of the joint to better be able to distribute weight across the joint surface that has been damaged by arthritis and other conditions. So it's usually a reaction to damage and arthritis, and we can see them on radiographs. A little more about osteoarthritis. Before the age of 55, OA occurs equally in men as in women. After the age of 55, it's more common in women. Being overweight increases the risk of OA in the hip, knee, ankle, and foot joints, and we'll talk more in depth about weight and how it relates to osteoarthritis. Some people might not have symptoms of OA, even though we can actually see changes on an X-ray. So some of the stats. It's estimated that about 1 in 6 to 8 Canadians suffer from osteoarthritis. Approximately 50% of those suffering from arthritis are under the age of 65, and there's roughly a new diagnosis of OA every 60 seconds here in Canada. And this can result in terms of our labor and workforce in almost 30% of the employed labor force, which is about almost 1 in 3 workers, having difficulty working due to osteoarthritis. Arthritis drives about $12.6 billion in direct healthcare costs, and this represents actual healthcare expenditures. And even more staggering of a number, even larger than that, is arthritis drives about $20 billion in indirect healthcare costs, and this represents lost productivity and taxes. So kind of just looking at arthritis, what we can do in terms of prevention, what causes it, what are the risk factors, just bringing everything back to the key things about most chronic conditions we see. Prevention is paramount. Prevention is paramount. And being able to prevent something before you have it is the best way to be able to treat something. So looking at risk factors, we have non-modifiable and then we have modifiable risk factors. Non-modifiable risk factors include age. We can't change our age, our gender, can't change our gender, and genetics. Much as we'd like to, but we can't change our genetics. Modifiable risk factors, these are things that we can change. Overweight, obesity, we can change our weight. Joint injuries, we can prevent injuries or try to prevent injuries as best we can. Infections, again, we can do our best to try to prevent infections, and our occupation. We can always change our occupation. Put a few little, if you notice on the right side there, not risk factors, but things that we commonly sometimes associated with arthritis. Cracking your knuckles. I thought I'd talk a little bit about that because I've always, even as a child, I always heard cracking your knuckles increases your risk, you're going to have arthritis. So I found a study, and they examined the hand radiographs and the x-rays of about 215 people. Their subjects were about 50 to 89, and they compared the joints of those who regularly cracked their knuckles compared to those who did not. The study concluded that knuckle cracking did not cause hand osteoarthritis, no matter how many years or how often a person cracked their knuckles. Running, sometimes we hear that running can increase our risk of osteoarthritis. Another study that I found here, I think this is about 2010, they found runners delay the onset of osteoarthritis by about 12 years on average compared to those who never exercise. So they're not just looking just at running, they're also just looking at exercise in general. Those who got the most benefit from running ran about 6 to 20 miles a week. And by the end of the study, 20% of the couch potatoes had pain and disability compared to 5% of the runners. So the runners as well also had greater bone density and less bone mineral loss over time. So no surprise there. Reduced the risk of osteoarthritis, but also had better bone density, reducing the risk of osteoporosis. So we'll look at the non-modifiable risk factors first. Age. The risk of developing arthritis increases with age. Older we get, the more possibility we have a chance of developing osteoarthritis. As we age, our cartilage is less able to handle normal stress of day-to-day activity. And as a result of this, our ability to put weight on the joint decreases. Here's a quote that I took from a study I found from USA Today. Arthritis of the knee is striking Americans at younger ages. And what they did was, this was a study where they just looked at different decades. They looked at the 90s and 2010 and the ratio of osteoarthritis in the knee. And what they found was the age of diagnosis in the 90s compared to 2010, the age of diagnosis has moved from 69 to 56. So 13 years earlier, people are being diagnosed with osteoarthritis compared to 20 years ago. They also found that between the ages of 45 and 54, these people account for nearly 5% of all knee osteoarthritis cases in 2010. while represented only about 1.5% of knee OA cases in the 90s. So almost more than tripled the amount of OA in that population. And some of the possible causes of what they looked at or are thinking about is obesity, and looking at that, that's a modifiable risk factor, and knee injuries. And both of these have become more common in the past decades. So kind of linking it all back together, both of these are modifiable risk factors, obesity and knee injuries. So just think about that. Gender. Most types of arthritis are more common in women. This is also taking into account autoimmune arthritis as well, which are most common in women. 60% of all people with arthritis are women. So some of the possible reasons they've been looking at within the differences in genders and just in terms of some of the research they've been doing is, one is biology. Women are designed to give birth, and they also have wider hips. So basically, with being designed to give birth, the tendons in women's lower bodies are more elastic than men for this birthing process. When the joints have less stability from having larger elasticity, they can actually become more prone to injury. Because women hips, look at the hips part, because women hips are wider than their knee joints are not aligned or as straight with their hips and knees as men's. This alignment can lead to higher rates of knee injuries, a modifiable risk factor, and injuries can lead to osteoarthritis later in life. Experts have also found that women who play soccer, for instance, have at least 3 to 4 times the number of knee injuries as men who play soccer. Looking at genetics, this is another thing we cannot, or why women tend to have a higher risk of arthritis. Genetics, osteoarthritis and arthritis is seen to run in families. They found that there's a genetic link amongst women. Women whose mothers develop OA will probably find that they'll develop it in the same joint at around the same age as their mother did. Autoimmune arthritis is higher in women. There's also a genetic component to autoimmune disorders in women and having higher amounts in women as well. Hormones, female hormones may have an effect on the cartilage that sits between the bones of our joints, and that cushions these joints and the bone to prevent pain and allow joints to move about slowly. They found that estrogen can protect cartilage from inflammation, and as estrogen levels go down later in life, such as postmenopausal, which is so postmenopausal women have higher rates of osteoarthritis. They lose protection that may have a higher risk of developing OA. They've even found that this is true when women are taking HRT therapy as well. A recent study of about 1.3 million women in their 50s found that hormonal and reproductive factors, such as going through puberty at an earlier age, having more children, and taking HRT were all related to whether they had knee or hip joint replacement surgery later in life. They found, this is pretty interesting just relating to hormones, they found that women who started menstruating at age 11 or earlier had a 9 to 15% higher risk of needing hip and or knee replacement surgery as an adult. Additionally, women who used HRT after menopause were at a significantly higher risk of knee and hip replacement surgery as well. They even looked at giving birth as a risk factor, and they found that with each birth a woman has, the woman's risk of needing knee replacement rose by 8% and hip replacement by 2%, all related to hormonal fluctuations. Obesity, and this is, again, a modifiable risk factor, but this is also relates to gender as well. Statistically, more women than men are obese or severely obese, and obesity plays a role in OA, again, modifiable risk factor. Just making you all aware to make the connections here in terms of modifiable risk factors, especially weight. Women who have gone through menopause tend to have more belly fat, which puts more pressure on their lower joints. So let's look more specifically at the modifiable risk factors, the things that we can change. Overweight and obesity. Overweight women have nearly 4 times the risk of developing knee OA than non-overweight women. And for men, 5 times greater risk. They found that persons in the highest quintile of body weight have up to 10 times the risk of developing knee OA than those in the lowest quintile of body weight. And it just goes to show you that every pound adds up, especially when we're looking at our joints and the pressure that we're putting on our joints. Every extra pound you gain, you add 3 pounds of pressure to your knees and 6 pounds of pressure onto your hips that then your joints have to carry with every step. Being only 10 pounds overweight increases the force on the knee by 30 to 50 pounds with each step. So looking at weight loss and the impact of weight loss on arthritis of the knee. And this is the data they extrapolated from the Framingham study. Among women with a baseline BMI greater than or equal to 25, and usually 26 or above is considered overweight, weight loss is associated with significant lower risk of knee OA. So lower weight, lower risk of developing OA. For every 11 pounds they found, so about a drop in 2 BMI units that the subjects lost, the risk of knee OA dropped by greater than 50%. And they also found comparably so that comparable weight gain was associated with an increased risk of developing knee OA later in life. Some of the weight loss basics that they concluded, and this is just very basic, they stated that an initial weight loss goal should be about 10% of body weight. And if patients are successful at achieving this, further weight loss can be attempted only if it's appropriate based on BMI and what their actual body weight is. Recommended rate of weight loss is 1 to 2 pounds per week. So joint injuries. Joint injuries are a modifiable risk factor that we can reduce our risk of developing joint injuries. Can't necessarily prevent them, but we can do things to try to reduce our risk because they are a risk factor. Injury can lead to arthritis, and when a ligament or supporting structure is damaged, causing abnormal mechanics, it causes abnormal mechanics in the joint. This greatly increases the stress on the articular surfaces, which over time wears out and can cause arthritis. One of the major ones that we'll look at in 2 studies is the ACL, or the anterior cruciate ligament. And this is a ligament that's in the center of our knee joint, keeps the tibia from moving forward, keeps forward on the femur, Commonly athletes can sprain or damage this ACL when trying to pivot, and it creates a lot of instability in the knee and a lot of buckling that can occur. So here's one study about joint injuries. This was an interesting study, the first one. They did about 1,300 people, and they started measuring these people at about 22 years old, followed up about 36 years later, and they looked at knee injuries, whether these people had suffered knee injuries before, after, what was the risk of developing arthritis. And they found that about 14% of the participants who reported a knee injury had developed osteoarthritis in their knee later in life, compared to only about 6% of the subjects who developed OA, so more than half and less of that of those who did not have any sort of injury. Another study, 80% of American football players with a history of knee injury showed signs of OA 10 to 30 years after retiring. So 80% of these players, which is significantly higher than the normal population of people who have arthritis. Here's another one. 82% of female soccer players had radiographic changes, so X-ray changes in their knees 12 years after tearing their ACL. And about 51% of these female soccer players met the criteria for having arthritis. Another one looking at men, 78% of male soccer players had radiographic changes in their injured knees 14 years after tearing their ACL. And what was interesting was they took some cartilage and synovial fluid samples obtained from some of these players immediately after tearing their ACL, and they found there was a rapid onset of damage to type 2 collagen and an initial increase in proteoglycan content associated with osteoarthritis. So even after they had just damaged or suffered a significant injury to their knee, they were starting to, in terms of the physiology of their knee, start to exhibit osteoarthritis characteristics. This is something that just came out of Stanford. It was a mice study, but it was looking at initial damage, so damaging a joint and the role of inflammation in the immune system in terms of arthritis. And what they found that when there's an initial damage to the joint, sets in motion a chain of events that can escalate with the body attacking this key joint in similar sort of way as if it was trying to attack a virus or a bacteria through something called the complement system. So they were proposing there was actually even an osteoarthritis, which is not thought of as an autoimmune disorder, that it was somewhat acting in certain ways as an autoimmune disorder, where the body was attacking itself after joint injuries. So possibly relate this to athletic injuries, and how that increases our risk of developing osteoarthritis later in life. Because what they found was when they damaged mice, some of their joints, and then knocked out this complement system, there was no development of arthritis afterwards. So basically what they concluded from this whole thing was basically a balancing of the immune system and trying to keep everything in check, because there may be a autoimmune, in a way, type of effect in terms of osteoarthritis that we've never really thought of before, especially after joint injuries. Infections is another modifiable risk factor. The type of arthritis we can see called infectious or septic arthritis. And people who are at higher risk for developing this are people with chronic RA, systemic infections like HIV, gonorrheal infections, certain types of cancers, IV drug abusers and alcoholics, people with diabetes, sickle cell anemia, SLE, or people who have had recent joint injuries or surgeries. In adults, it usually affects the wrist, one of the patient's weight-bearing joints, most often the knee, although about 20% of adult patients have symptoms in more than one joint. And why this is important, because it can have a very sudden onset or very immediately or within 13 to 14 days. And this is considered a medical emergency because Staphylococcus, one of the bugs that can cause septic arthritis, is capable of destroying cartilage in only 1 to 2 days. So why is this important to mention? Because about 70% of patients will recover from this without permanent joint damage, which still leaves about 30% of those who will not have be left without joint damage after having a septic arthritis attack. However, many patients will develop OA or deformed joints, and more importantly, children with infected hip joints from this sometimes suffer damage to growth plates. And if this treatment is delayed, infectious arthritis has a mortality rate between about 5 to 30%. Last modifiable risk factor is occupation. Jobs involving manual labor with repetitive motions. Some of these include farming, construction work, and lifting heavy loads. Mostly manual labor jobs that involve repetitive knee bending and squatting. Those are the two motions that are mostly associated with an increased risk. Here was a study. You guys can look this one up if you like. They went over a whole bunch of different jobs and showed the increased risk of OA compared to the normal population of how many people get osteoarthritis and the increased risk. And they found that heavy manual labor and stresses in the work environment were major predictors in the development of hip osteoarthritis. Just looking at occupation, looking at baseball players specifically. Baseball players have an increased risk of developing OA in their shoulders and elbows due to repetitive motion of pitching and throwing. The average Major League Baseball pitcher can throw over 2,000 pitches per season with little rest between games, maybe a week. And excessive joint loading forces at the extreme of the motion and repeating this many times over and over and over again can contribute to joint and connective tissue wear and degeneration, which can increase the risk of osteoarthritis. So that repetitive motion of throwing 3,000 pitches a season significantly increases the risk. So kind of just bringing it all together here, not looking at the risk factors here, but looking at the very pillars of health, diet, and lifestyle. And this was a trial they did looking at exercise and dietary weight loss and dietary changes in obese and overweight adults with arthritis and what the outcomes were. So they took 4 groups. They took a healthy lifestyle group, and they called them sort of a placebo-ish group. They had a diet group, a group who just did exercise, and a group who did diet and exercise. And diet and exercise, the group outperformed all groups in self-reported measures of function and pain, and in performance measures of mobility. Plus, side note, they also lost more weight. So question mark, surprise. Are we surprised that diet and exercise together, compared to looking at individually, helped people with function, reduction in pain, and lost more weight? I hope not. So the dietary principles that they did with these groups is very basic dietary principles: low sodium diet, low fat, balanced nutritious foods. But one thing they also did with both the diet and exercise and just the diet group alone was they provided some dietary counseling. And they basically had classes for these people where they showed them how to cook healthy meals, showed them what a nutritious plate of food looked like. So it really educated them in terms of healthy food. So it kind of just explains the importance of, if you don't really know what a healthy diet looks like, is to get some sort of dietary counseling in terms of to be able to get some help to be able to design your meal plate for a healthy meal. The exercise that they did for these people with osteoarthritis of the knee, they only did 3 days a week, and what it consisted of: a 15-minute aerobic phase, then a 15-minute resistance training phase, after a second aerobic phase of 15 minutes, and then a cool-down phase of about 15 minutes, so an hour in total. The aerobic phase that they did include walking, and they kept the heart range at about 50 to 75%. And the resistance training program consisted of doing 2 sets, 12 repetitions of leg extensions, leg curls, heel raises, and step-ups. They also used in some of the individuals cup weights and weighted vests to provide extra resistance, and only about 1 minute to 1.5 minute rest intervals between exercises. So basically, this is just showing the importance of people with arthritis, that diet and exercise together can be part of the treatment protocol. So just looking at arthritis here and what is exactly going on, it's kind of a teeter-totter effect. Cartilage remodeling, just like most things that are remodeling and turning over in our body, it's a teeter-totter. We have things that increase it and things that decrease it, and we want to balance between these two. When we have too much of a net decrease, then this is where cartilage becomes eroded. So if we look here, we can look at matrix synthesis, and then we look at protease to inhibitor ratio. And I want you guys to kind of take a look at, just remember this protease to inhibitor ratio, because we're going to talk a little bit later about something called matrix metalloproteases and their role in terms of arthritis and what we have available to help with those, because they're a pretty novel mechanism for being able to help with arthritis. So this is kind of a teeter-totter for someone who may, say, be on the way to have or have it. They have a net decrease in terms of the synthesis and protease to inhibitor ratio. So here's a diagram of a normal knee versus an OA knee, different from the radiological one we showed earlier. And what we can see here is we can see some osteophyte formation here on the OA side, and those are those bony spurs that we're laying down. We can see eroded cartilage that's here compared to the normal side. We can see bone cartilage and fragments here inside the synovial fluid that's been eroded and degraded. And we can also see a joint fluid with a low concentration of hyaluronin. And we'll talk a little bit later about hyaluronic acid, that cushioning that's inside the joint capsule. So what is available in terms of health? What's out there? What has some research, good and bad, for arthritis and be able to help with the pain and increase our function? So exercise. This is looking just at exercise by itself. So I ask the question: does it reduce pain and improve function? So there's a lot of evidence out here in terms of arthritis with a variety of different things. So I tried to find a lot of meta-analysis which review a lot of data at once, or Cochrane reviews, which make an endpoint measure of looking at all the data itself, instead of just calling up many different trials trying to find a nice summary of it. There was a Cochrane review, and they found that on average in people with OA of the knee, exercise results in a modest reduction in pain and a modest improvement in physical function. In the short term, exercise program to reduce knee pain by 1 point on a scale of 0 to 20, improve knee function by 3 points on a scale of 0 to 68. And they found the same results, except no increase in function with exercise of the hip, with OA of the hip. So then we look at high intensity versus low intensity aerobic activity, and if there's a difference in terms of its effects on helping with osteoarthritis. And they found that there was no statistical or clinically significant differences between high intensity and low intensity aerobic exercise in people with OA of the knee in terms of these functional measurements here. So whether we're doing really high, pushing ourselves really hard, or just doing a low intensity, there was no statistical differences. So I guess the conclusion we can take from this is if you do have osteoarthritis, you don't need to go out there and run on a treadmill at 10 to be able to get benefit. A good low-intensity aerobic activity is just as effective. So looking at aquatic exercise, I know a lot of older individuals like to do aquatic exercise because it's less strainful on the joints. So they did a Cochrane review in terms of aquatic exercise for OA of the hip and knee, and they found that it can decrease pain by 1 point or more, and again, function may improve by 3 points or more. So just as effective as regular aerobic training, maybe a little better for functionality though. So vitamins and prevention. I wanted to look here just at a few vitamins and the roles in terms of a little bit of treatment in terms of what's available, but also in terms of prevention, because I think this is where they come in for arthritis. Looking at vitamin C, the Framingham Osteoarthritis cohort study, they found that moderate intakes of vitamin C, depending on what your perception of moderate intake is, theirs is 120 to 200 micrograms a day, yielded a 3-fold lower risk of osteoarthritis progression, so progression of the condition. 2003 study, almost 900 milligrams a day, was able to reduce pain in OA versus placebo. And then here's the contrary study that showed a deleterious effect of vitamin C. And I had to put in there a guinea pig study because it was a guinea pig study. The other ones were human studies. They found that high-dose vitamin C, which is in their minds 1 gram a day, developed the most severe osteoarthritis of the knee and showed the worst cartilage damage. So they fed these guinea pigs different amounts, and the ones who got 1 gram a day ended up developing the most severe osteoarthritis, these guinea pigs, not humans. Vitamin D, again, looking at the same Framingham cohort, they found the risk of osteoarthritis progression was seen to increase 3-fold in participants with the lowest levels of vitamin D intake and serum levels of vitamin D. With lower levels of vitamin D, more severe progression. 2010 study was looking at it in terms of treatment or help. Found that vitamin D did not reduce the pain of knee OA, and it did not slow the disease's progression once someone had it. So they looked at about 2,000 IUs a day. Looking at vitamin E here, one of the, a long time ago, looking at 30 plus years, giving out 600 IUs a day, 52% of these patients who did have pain received good analgesic effect, whereas only 4% of the patients on placebo received a good analgesic effect. 1990 study, 400 IUs a day compared to diclofenac, which is an NSAID medication to reduce inflammation, and has an analgesic property as well for reducing pain. 2 treatments were equally as effective for reducing pain and increasing mobility. And then about a 10-year ago study showing the opposite side of things, given 500 IU, so right in between the last 2 studies, vitamin E showed no benefit for the management of symptomatic knee OA. So just giving you guys something to think about, showing you the good and the bad. So looking at Boswellia, and if you notice the first line there, I say one of the best. Just after looking these 3 trials that I'm going to highlight here, at least in my opinion, in my experience, it's probably one of the best things I think we have naturally individually. So we just have to look individually for osteoarthritis, not just based on results, but based on the research that we have available to us. So here was one trial, one of the first ones, 1,000 milligrams a day, 40% boswellic acid standardization. Pain index fell pretty significantly. Loss of movement index reduced significantly, and swelling index went down significantly. And one of the interesting things with the swelling was they also found a frequency in terms of which the knee swell was substantially decreased. With this trial, though, they did not find any radiographical changes in terms of the knee, just these measures here. Second trial, same dose, but studied it versus valdacoxib. They found Boswellia was slower in onset than the drug in terms of being able to help, but by the end of the 2nd month was providing comparable symptomatic relief. So the 2 treatments worked effectively and the 2 treatments worked equivalently effectively for the rest of the trial. So just as effective by the end of the trial. But the interesting part of it is 1 month after stopping the treatment, completely stopping both, drug group back to square one. Pain was back to where it was previously. The Boswellia group still experiencing relief, which is pretty interesting. And Boswellia is a pretty cool mechanism because it helps to block 5-LOX, which is is one of the first enzymes released in the synthesis of immune cytokines known as leukotrienes. But it's also able to reduce the another activity of a pro-inflammatory enzyme known as HLE, or human leukocyte elastase. And to date, Boswellia is one of the only substances known to reduce both HLE and leukotriene. And part of its mechanism for being able to help with arthritis is through this. So looking at another trial using a lower dose of Boswellia, they found statistically significant dose response improvement in pain. So the higher doses got a better response in terms of pain and physical function. Symptomatic alleviation was faster in the higher dose, different than the past study where they showed that it took a little while for the onset. This was as early as 7 days, and some people noticed results or some sort of symptomatic alleviation. And the interesting thing is the significant reduction in synovial fluid levels of matrix metalloprotease 3, which is a cartilage-degrading enzyme. And I'll go a little bit with a diagram in a few slides, but that's a pretty significant finding right there, because these MMPs are implicated in a variety of different conditions, anything from Alzheimer's to asthma, a variety of different things, and it was able to help reduce these directly in the synovial fluid. So the conclusion of this is Boswellia works pretty effectively. I found this from a doctor online, pretty respected doctor, and how he likes to use it is, he often starts his patients on doubling their dose a little bit for in the acute phase to try to get that loading dose or that fast yield response that we found in this dose response, and then long term kind of keeps about 400 milligrams of Boswellia, and that's where he finds the best effect. Curcumin. Here was a study comparing it to phenylbutazone, and they found that both produce measurable improvements in terms of joint flexibility and walking time. If you notice here on the bottom right, there's a product that AOR carries in its unavailable line called Inflammation Relief, and this is probably one of my favorite products we have in the entire AOR line, especially for arthritis, especially for anything inflammatory in nature. And the reason why is because it does combine our nanoavailable Boswellia with our long-vita curcumin, or significantly more bioavailable curcumin, together in the exact same product. And you can get a therapeutic amount or some relief within a 1 capsule a day with these two things combined together, which I think is pretty significant because you reduce the amount of capsules and products someone needs to take, you increase the chance of compliance and a better chance of getting a better outcome. So really good product to look at, especially if you're looking at arthritis and the pain and the function and trying to get that back. Another study on curcumin compared to placebo, reduced pain in the curcumin group, stiffness lowered in the curcumin group, physical function improved as well, which is important. And one of the interesting things I found was they found a significant improvement in social and emotional function and general well-being. So the group who took the curcumin just felt better overall by the end of the study. They also found, because some of the participants were on pain-killing medications like NSAIDs and acetaminophen and celecoxib, they found the curcumin group was also able to reduce the amount of drug they needed as well. So looking more specific at these MMPs, the MMPs play an important role in tissue remodeling associated with a variety of different physiological and pathological processes, such like tissue repair, cirrhosis, arthritis, metastasis, a variety of different things that are implicated in terms of chronic conditions. So they found that it's been involved in a variety of chronic conditions from psoriasis, Alzheimer's, arthritis, asthma, cancer, a variety of different things. And two of the things that do have some documented research for being able to disrupt these is Boswellia and curcumin, which makes them a really good combination to use them together for not just arthritis, but when you're looking at targeting this sort of mechanism, so drugs are starting to be developed targeting this mechanism. This is probably one of my third favorite herbs for arthritis and pain effect is Harpagophytum, also known as devil's claw. So several studies that combine them And the results that we get after about 8 to 12 weeks helps reduce pain and improve physical functioning of people with OA. There was they did a 4-month study versus diasterin, which is a slow-acting drug for OA, found to be as effective for improving pain in the hip and knee as the drug after 4 months. And they also did another study just looking at pain relief compared to Vioxx, and they found that its analgesic effect was worked just as well as Vioxx, the devil's claw. And how this is able to, and how it works, is by blocking enzymes such as cyclooxygenase. It also helps to increase glucosamine synthesis, which helps to promote and form new cartilage, which is important when we have degraded cartilage. You can see up here on the upper right, AOR carries this in a product called Advanced Joint Support, along with Boswellia and hyaluronic acid, which we'll get to in a minute. So here's a diagram of some of the pathways in terms of osteoarthritis and a variety of, not just OA, but many chronic diseases. And we can see how these three things, or Harpagophytum, Boswellia, Curcumin, fit into this. Curcumin has been shown to inhibit NF-kappa B. We can see NF-kappa B in a variety of different parts here. Also help with the MMPs, also cyclooxygenase 2, tumor necrosis factor alpha we can see on there, and IL, interleukin I1 beta. In Boswellia helps with tumor necrosis factor alpha as well, MMPs, and different mechanism, the 5-LOX enzyme as well. Then our Harpagophytum mostly works upon cyclooxygenase. So looking at SAMe, it was a 16-week study. They did 1,200 milligrams a day, studied directly compared to celecoxib, and they found on the first month, celecoxib showed more significant reduction in pain than SAMe, but by the second month, there was no significant difference between both groups. SAMe had a slower onset of action, but it was found to be as effective as celecoxib in the management of symptoms of OA after the second month. There was a U.S. Department for Health and Human Services review. They did a meta-analysis of about 10 trials, and the conclusion that they found was SAMe demonstrates an effect to be able to decrease pain in OA. Looking here at hyaluronic acid, here's one study they did in people with achy knees, documented 240 milligrams for 12 weeks, and they found the individuals had significant improvement in knee joint function and just overall comfort. Some of the rationale in terms of how this worked, studies have shown that hyaluronic acid content in osteoarthritic cartilage is much lower than normal, so people who have OA have less hyaluronic acid content in the cartilage than healthy controls. And hyaluronic acid itself was able to exert an anti-inflammatory effect and could quite possibly reduce cartilage and meniscus degeneration that occurs. AOR carries it as a standalone with lysine and vitamin C, but it's also, just as I mentioned, with the Harpagophytum and Boswellia, found in Advanced Joint Support. Looking at MSM, two of the larger trials here. One trial, 3 grams BID, twice a day. Another one, 500 milligrams 3 times a day, or TID. And what they found there was a significant improvement in pain outcomes in the treatment group compared to placebo. However, just to highlight some of the methodological issues and concerns over optimal dose and treatment period were highlighted in the studies. So some of the ways they conducted the studies, and the dosages are very different in terms of the studies. So conclusion, patient who took MSM reported reduced pain and improved physical function, but they found no evidence that it had a general anti-inflammatory effect. So they measured C-reactive protein levels and ESR, or erythrocyte sedimentation rates, and they found that it did not affect these at all. So looking now at the heavyweight, the two things you always hear so much about for osteoarthritis and arthritis in general, Glucosamine Chondroitin, and there's such a variety of evidence out there, you can kind of spin it whatever way you choose to. So I'm going to try to look at just systematic reviews on large trials and conclusions, just to get a better picture of everything, because we could pull trials for either end of the spectrum. So it's a really hard thing to find an absolute conclusion. That's the whole point that I'm trying to raise here with these. So looking just specifically at glucosamine, this is a Cochrane meta-analysis, or Cochrane review, 2005. They found only glucosamine sulfate appeared to be superior to placebo in the treatment of pain and functional impairment resulting from symptomatic arthritis. Then they looked at this again. The data between 2005 2009 did an update, found same conclusion as 2005. So their conclusion in terms of glucosamine, and I do say this with a grain of salt because they are very liberal, we'll say, in terms of their conclusions, may reduce pain, glucosamine, may improve physical function, and will probably not have any side effects. Recommended dosage is 1,500 milligrams a day or 500 milligrams TID. So looking more specifically at two highlighting good, two highlighting bad here. Two large-scale trials, 2001, 2002. These are, I believe, 3 years long, these trials, and they had more than 100 participants. Both these studies showed benefit for glucosamine treatment and an improvement in symptoms, but also an improvement in joint space narrowing on radiographs. So we go back to that radiograph way on slide 8, I believe it was, on that joint space narrowing that occurred. They found, this is a 3-year-long study, they found that after 3 years there was an improvement in this joint space narrowing with glucosamine supplementation, which I think is pretty significant. Then if we look at two clinical trials here, 2002, 2004, on the opposite end of the spectrum, these were smaller trials, shorter in duration, 6 months. They did not detect any benefit for glucosamine in terms of the parameters above. I'm just trying to use my logical brain here. I'm looking at the differences between these. Some of the thoughts, two ones that were negative, smaller, shorter duration studies. The two large ones showed benefit, longer duration studies, 3 years. So maybe there is something in terms of long-term use of glucosamine using in comparatively to 6 months versus 3 years in terms of its ability to be able to work. Larger scale study 2 in terms of more people, better sample size versus smaller sample sizes. Usually larger scaled with larger groups probably have more weight. There was a specific study looking at glucosamine called the Guide study, 6 months in duration, 1,500 milligrams of glucosamine compared to 3,000 milligrams of acetaminophen and a placebo. Glucosamine users had a statistically significant improvement, while the acetaminophen group, despite its high dose, was not significant from placebo. So what's interesting from just kind of concluding, looking at a variety of these different things is, maybe we can make a suggestion here that glucosamine, unlike pain relievers such as NSAIDs, can actually help prevent destruction of cartilage. That is the hallmark of osteoarthritis, because if we're looking at the last study in terms of joint space narrowing, glucosamine had a significant effect in terms of this joint space narrowing that hasn't been showed with acetaminophen. Two products here that we carry our glucosamine in, one MSM plus glucosamine, combining two things with some data, and then glucosamine as a standalone product in a vegetarian form. So looking at chondroitin by itself here, 2007 meta-analysis looked at 20 trials, large-scale, methodologically sound trials indicate that the symptomatic benefit of chondroitin by itself is minimal or non-existent. So reviewing all this in the conclusion, they found the results are mixed. We found good and we found bad. The smaller studies tended to find it effective, while the larger trials tend to find that it wasn't. And in the studies where they did find benefit, they showed that it was about 2 to 4 months before we found any benefit from chondroitin supplementation by itself. They also found that there was no dose dependence in a way. 800 milligram was as effective as 1,200 milligrams a day. And an interesting thing they also found from this was they found that sequential 3-month use twice a year, so using 3 months on, 3 months off, 3 months on, 3 months off of chondroitin was as effective as using it continually through the year. So now looking at both of these together, because most people usually use these things in together or think of them as one. So here was one of the large trials. It was called the Gate study. It was done in 2006. It was 6 months long. They found that glucosamine plus chondroitin together had no statistically significant effect upon symptoms of osteoarthritis. This is the interesting part. Moderate to severe pain group, people with moderate to severe pain in OA, the combination of chondroitin and glucosamine was found to be subjectively more effective in treating pain than celecoxib, both chondroitin by itself and glucosamine taken by itself. So both of them together, more effective in terms of treating pain than celecoxib. Here's looking at a large-scale meta-analysis, 2010, and they found there was no benefit for the glucosamine and chondroitin. But when we look at this a little further, just to try to break it down, it's pretty interesting. So they excluded all RCTs involving less than 100 people, which left out a lot of trials. Studies with lower doses, less than 800 milligrams of chondroitin, less than 1,500 milligrams. They took those ones out as well. So out of 80 possible studies, they only included 10 studies. And the majority of the published studies out of these 80 are in fact actually positive. And looking more specifically at the Gait study, I think the interesting part of it is the combo outperformed Celebrex in moderate to severe OA, so outperformed it. And I think this is interesting because when we look at Celebrex itself, it's been shown that about 7% of people who take it stop taking it because of side effects. And about these people who do experience side effects from Celebrex, about 13% experience hypertension or high blood pressure, 11% bowel issues, 9% fever, and almost 9% indigestion or heartburn. There's some of the common reasons why people stop this medication, and this combination was actually, glucosamine and chondroitin together was actually found to be more effective in reducing pain. And that just brings us to the last point there. The safety of glucosamine and chondroitin supplement is well recognized. So when we're looking at safety, side effects, it has a very good safety profile in comparative to some of the other measures that are out there for the pain. So I guess the conclusion of this whole study is just when we are looking at meta-analysis and Cochrane reviews and all these things, we do have to be cognizant in terms of what the parameters are in terms of keeping things in or keeping things out. So just in conclusion here, prevention is paramount. Just with everything, every chronic disease we can find, prevention is paramount. So adequately looking at our diet, our lifestyles, and making sure we exercise is paramount for prevention. Prevention is the best medicine. So we're actually looking at treating osteoarthritis or arthritis in general, the pain and inflammation of that. I like to look at like a two-tone approach. We got to look at quelling chronic inflammation and highlighting chronic inflammation here, and then also doing what we can to repair and replace damaged tissues that are being eroded in terms of arthritis. So some of the best things, at least I believe, based on the data, is Boswellia, Curcumin, Harpagophytum are some of the best things we have for being able to reduce the pain and improve function and reduce chronic inflammation that we do see as that side of joint pain and inflammation. And then repairing or replacing damaged tissues, we want to look at things that are going to provide substrates for the glucosamine matrix, which is an important component of making things like connective tissues and cartilage and tendons, things that are going to stimulate the synthesis of proteoglycans and hyaluronic acid, that fluid that's going to be in our joint capsules and our cartilage to help provide shock absorbency, and things that are going to decrease the catabolic activity of chondrocytes. And these things can include things like hyaluronic acid, glucosamine, and chondroitin. So taking these two-toned approach of inflammation and repairing and replacing is probably one of our best bets for helping this condition. Here's some of the selected references that I have. If there's anything that was left out here, if people would like some more information, they're more than welcome to email us for some more information if they like so. You can find us at tech@aor.ca. So I just want to thank everybody for listening to the webinar. We will be here for a few more minutes answering some more questions. And if you cannot reach us here, please email us at tech@aor.ca. And be on the lookout for our next webinar series, which will be on stress, presented by our very own Dr. Paul Herkel in October. So thank you guys very much.